administration has successfully set the unshakable foundation for achieving our goal of 100% health insurance coverage, and as a result, access to affordable and quality health care, so that never again should a Kenyan needlessly suffer or be driven to poverty because of medical bills.
Kenya's progress towards leaving no one behind through the attainment of universal health coverage got a boost during the official launch of the national scale-up of UHC. But what does this mean? My name is Dr. Mercy Korir, and on this episode of KTN News Health Watch, we unpack what the UHC policy is all about, what you should expect, and the critical milestones that will anchor this program regardless of the government of the day. This is a foundation whose progress started many decades back, but accelerated in the last 10 years with changes in the health sector, including devolution and reforms in NHIF, now the National Health Insurance Fund.
Jamani, sisi wengine kina mama tulikuwa tumeenda kudungwa shindano tusizae. Lakini tuliposikia Linda Mama Care, yani sasa Mheshimiwa Rais kura tunaziongeza. Tunazaa bila matatizo. Kwa sababu tunajua hatulipishwi hata shilingi. Ni kitabu chako, unaenda kununua cha shilingi 5, unaandikishwa Linda Mama, unazaa nywe. Jamani, tufanyiwe nini?
Monday's launch of the Universal Health Coverage Policy marks the scale-up to all 47 counties in Kenya after the pilot program initiated in December 2018 in Kisumu, Isiolo, Machakos and Nyeri counties.
Indeed, there is an unmet need for healthcare, that indeed there are Kenyans who are at home, who are not going to hospital because they cannot afford care. And so when we opened the doors in those 4 counties, we saw a 40% surge in services, in workloads at the outpatient facilities, in the inpatient facilities.
The UHC policy will be implemented through the NHIF. The new reforms, such as paying uniform rates to public, private and faith-based institutions accredited under the NHIF, is one of the major changes towards UHC. Currently, there are 5,648 government, 1,744 private and 274 faith-based hospitals.
The levels start from the level 1 at the community, the level 2, the level 3, level 4, level 5 and level 6, which is the referral hospitals. Now, as we are looking towards getting to being a strategic purchaser of health, traditionally NHIF used to reimburse hospitals based on actually even private negotiations that were had in the past. So we had a lot of discrepancies in the way and manner that we are reimbursing hospitals. But in the reforms that we have, one of them is to standardize across all KEF levels. So if a hospital is a level 3B, for example, whether it is in private, public or faith-based, for any service that is contracted for, we will reimburse at exactly the same rate. And being a social health insurer, this is a huge step towards ensuring equity, fairness, and also ensuring sustainability of the fund so that we are able to cater for all members as they enroll.
Contributions to NHIF will be mandatory and employers will match their employees' NHIF contributions.
We have now as a country transitioned from input financing into the healthcare system, where we are deliberately injecting money to buy more medicines, injecting money to strengthen infrastructure, to focusing on covering every Kenyan with an insurance, so that each family has the ability to walk to a hospital and, using their insurance card, enjoy services. And if they're to visit a public facility, they should actually pay no fees at all.
In Kenya, we have close to 350 billion circulating in terms of our total health expenditure. In other words, the money that circulates in the health sector, and it's quite a huge sum, and these are statistics from the national health accounts that were held about 2 years ago. So this again is not the most current data, and perhaps we could even well have gone above the 400 billion mark. But that's the money that is in the health sector. And what we are trying to do for UHC in this country is to then rearrange that money in buckets that ensure that 350 billion is able to deliver better. If we break down the 350 billion, we have about 30% of that coming from government. So we have about 121 billion there coming from government. When we break it down again, we have another, say, 120-something billion coming from our partners, our external support, the people who support programs within Kenya. So our different partners, the unilateral, multilateral agencies. We have agencies such as Gavi, Global Fund, who support our malaria and TB, HIV programs. That's about 30%. If we then look at the remaining 30%, and again, I'm giving approximations here because it's a split across three, 100% divided by 3. The remaining 33% actually comes from the Kenyans' pocket. In other words, it's what we call out-of-pocket expenditure, meaning it is the money you remove from your pocket when you're going to a health facility to seek care. And what we want to do is to ensure that that money, you do not remove it when you're seeking care, but instead we transfer it into a mechanism where you're pre-financing for care.
In a phased-out plan, the government plans to cover 5.1 million households unable to afford monthly premiums, starting with 1 million at a cost of 30 billion shillings.
And we know that universal health coverage, the spirit of it, is that everybody who can pay should pay, and those who cannot pay to be identified and supported. Therefore, having a bill that enables that spirit will be key to us achieving universal health coverage. And we know that with how it has been previously as voluntary, very few members were actually contributing. I'm sure if you look at our numbers in the last financial year, with 13.9 million members registered, but at the end of the year having less than half, way less than half being active, is a challenge to even the social protection of our people. So by having people obligated to pay, and then those who cannot pay to be identified and supported, it's a true spirit of getting us to universal health coverage.
Under the comprehensive inpatient package, NHIF will shift from the varied reimbursements based on the kind of contracts facilities sign to reimburse all Level 3 facilities a uniform 2,000 shillings, Level 4 3,000 shillings, Level 5 3,500 shillings, and Level 6 facilities 4,000 shillings per person. Under the non-comprehensive package, Level 3 hospitals will get 1,600 shillings, Level 4 1,800 shillings, Level 5 2,000 and Level 6 hospitals 4,000 shillings per person. Medical outpatient capitations for Level 4, 5 and 6 hospitals increases from 1,200 to 1,400, while for Level 2 and 3 it will be 1,000 shillings for all healthcare providers. For dialysis, 19,500 shillings for 3 sessions per week will be reimbursed. For normal delivery and a maternity care package, NHIF will reimburse all hospitals 10,000 shillings at Level 3, 4, 5 and 6 facilities and 30,000 shillings for caesarean sections under comprehensive package. Minor surgeries will be covered up to 40,000 shillings in all facilities, major surgeries up to 240,000, while specialized surgeries will only be covered in Level 5 and 6 facilities for up to 480,000 shillings, down from 500,000 shillings. Basic chemotherapy will be at 25,000 shillings per session for 6 sessions, complex chemotherapy at 100,000 per session for 6 sessions, while radiotherapy will be at 3,600 shillings per session for 20 sessions. 15,000 shillings will be reimbursed for 1 bone scan per year, and 1 PET scan per year will be reimbursed at 40,000 shillings. Mental health, including rehabilitation for drug and substance abuse, will also be covered in the proposed changes.
I particularly urge our counties to urgently ensure that our health facilities do have financial autonomy. The funds collected by the facilities should be reinvested in those facilities for the benefit of all of us. The reforms currently underway at KEMSA and NHIF must be concluded for Kenyans to benefit from all these efforts.
What His Excellency is basically bringing out is the need for the county hospitals and even the national referral hospitals to ensure that every reimbursement goes back to the facility. So if a woman delivered in a hospital somewhere in Wajir, some sub-county hospital, rather than the money going into the Wajir account from NHIF, that money should go back to that sub-county hospital and support the operations at that hospital.
At the same time, the Kenya Health Financing Strategy for 2020-2030 was launched, the President directing that all government-sponsored programs to be consolidated by June this year.
The government has registered 1 million households, poor households, who are now fully covered by government, and 6 billion shillings was provided to NHIF for the cover of those families. And progressively, government will continue to increase the number of households until we reach our target of 5.1 million, so that every poor home is covered.
Critical to universal health coverage are 3 key pillars: accessibility, quality health services, and affordability, which is what the national scale-up of UHC means to Kenyans, such that no one suffers financial hardship due to seeking healthcare services. Dr. Masikorir for KTN News.